name is Julianna Simon, and I am an assistant professor in the graduate program in acoustics at Penn State and PI of the Basal Lab. This work was done by my graduate student, Molly Smallcombe, and she recently got her PhD this summer and is on to bigger and better things, so I'm presenting on her behalf. This work was also done in collaboration with the Muscle Lab at Penn State. So this talk is on investigation of focused ultrasound therapy for tendinopathies in an in vivo murine model. Tendinopathies are common and account for about 30% of the 120 musculoskeletal injuries each year. Tendinopathies, of course, cause pain, but also, if they're severe enough, cause mobility and functional impairment. The biggest challenge with tendinopathies is that the tendon, even after healing, will always be weaker after injury. And this is because these very well-aligned collagen fibers in the healthy tendon become disrupted after the tendinopathy and healing process, so it's not as able to withstand load. This, along with scar tissue formation and low vascularization, makes the tendon a very difficult target to treat to try to improve that collagen alignment and thus improve its ability to withstand load. Therapies for tendinopathies have variable reported success rates and range from very invasive to non-invasive. Open surgery, of course, is on the most invasive side, followed by arthroscopic surgery, where some probes are inserted near the tendon injury to debride the area, try to create a healing response. On the non-invasive side, physical therapy tries to create the same sort of healing response invasively and also make the injured area stronger. In the middle, we have these minimally invasive therapies of dry needling or extracorporeal shockwave therapy. Dry needling uses a thin gauge needle and repeatedly fenestrates the tendon to create microdamage to promote a healing response. Therapeutic ultrasound or shockwave therapy does the same by creating cavitation bubbles to promote a healing response. However, all of these therapies have extremely variable success rates on the order of 0 to 85% of patients showing improvement. Because tendinopathies are so common, a better treatment modality that consistently produces success is greatly needed. Histotripsy mechanically fractionates soft tissue by creating oscillating and collapsing bubbles. It was first developed at the University of Michigan in what's now called cavitation cloud histotripsy or histotripsy by using these very short pulses with very high negative pressures repeated at 1 to 10 milliseconds to create these cavitation bubble clouds that oscillate and collapse. Boiling histotripsy was developed at University of Washington and uses longer pulses to create that boiling bubble. An interaction of subsequent shock waves with this boiling bubble creates prefocal cavitation, and all of it together creates this homogenized tissue. Now, in both cases, there's a very sharp boundary between the normal tissue and homogenized or fractionated tissue in that response. However, tendons have shown resistance to mechanical fractionation in histotripsy. This B-mode image of a tendon shows that this tendon treated with conventional boiling histotripsy parameters that we can create bubbles. You see that hyperechoic activity in the circle. The bubbles are created, however, histologically, we see a thermal injury rather than a mechanical injury. And this is shown by the clumping of the fibers in H&E stains, or this lack of stain uptake in NADH stains, indicating lack of enzymatic activity or thermal injury. In tendons treated with cavitation cloud histotripsy, we see a similar result, where normal tendons show no response to the histotripsy therapy. If you preheat the tendon to 58 or 90 degrees C, you start to see more of a histotripsy response. However, at those temperatures, you start to have collagen hydrolysis, so now you're not even really treating tendon tissue. So this leads to the question, is focused ultrasound-induced microdamage possible in tendinopathy tendons? Previous work found that there is a narrow range of focused ultrasound parametry that mildly disrupts healthy ex vivo rat tendons. Now, to be clear, we would like to be able to prove at some point that histotripsy is possible in tendons, so that pure mechanical fractionation. However, for most tendinopathy treatments, we really want to just create this mild mechanical microdamage to promote the healing response. So these are right on the realm of those mild microdamage. So on the left, we see fiber separation for 1 millisecond pulses repeated at 10 hertz for 60 seconds. In the middle, we increase that to 10 millisecond pulses repeated at 1 hertz, however, only for 15 seconds to create that cavitation type injury, because if we treat for up to 60 seconds, that's when we start to see the thermal denaturation, like on the right side of the image. We wanted to investigate, will this fiber separation or mild fiber fragmentation promote a healing response? So we compared healing between focused ultrasound and standard dry needling in an acute tendinopathy rat model. To create a tendinopathy, we partially transected the Achilles tendon at 3 approximately equidistant locations across the tendon when used a contralateral tendon as a control. Then we treated half of the tendons with focused ultrasound at 1.5 megahertz, 1 millisecond pulses for 10 hertz. That's, remember, that left side, that fiber separation. And we did that by partially submerging the rat in a water bath, and we used imaging for guidance and monitoring of the hyperechoic or that bubble activity. Dry needling, we used a 30 gauge needle and fenestrated the tendon 5 times over about 20 seconds. We also collected blood before and after treatment and before euthanasia to look at growth factors and whether we were showing this healing response or growth factor response. Specifically, we looked at IGF-1, VEGF-A, and TGF-beta. Finally, after euthanasia, we would harvest all of the tendons for histology, with half of them going to histology for hematoxin ASN or picroserous red stains. The other half would undergo mechanical testing, where we would pop the bone in epoxy. The other side of the muscle would be in this sandpaper clamp, and then expose it to cyclic loading, then stress relaxation, finally by load to failure. What we found was that focused ultrasound performed very similarly to dry needling in the release of growth factors IGF-1 and TGF-beta. In both of them, we see that there's slight changes before after treatment. So we are definitely seeing a change from the treatment, but there's large error bars, so nothing was statistically significant. The trends, however, were the same for both treatments. In all cases, VEGF was too low to detect. That's not really a surprise because our 1 week of healing were very much in the inflammatory phase of healing, not in the angiogenesis. And so we see the IGF-1 and TGF-beta change, but VEGF were a little bit early to be able to detect. In histology, we saw that focused ultrasound and dry needling treated tendons showed inflammation or infiltration of fibroblasts because of inflammation. So the circles show the approximate treated locations. You can see this healthy or collagenous type tissue on either side of it. But if you compare to the control, instead of this nice fiber alignment, we have these open areas, and that's where the treatment happened, infiltration of fibroblasts surrounded by this normal healthy tendon tissue. But both of them looked very similar. Mechanical properties, however, we found that focused ultrasound performed as well or better than dry needling treatments for preserving those mechanical properties. In elastic modules, both of them showed a decrease after treatment, though focused ultrasound slightly better, not statistically significant. Similarly, a decrease in ultimate tensile strength. Maximum loads not significant. However, in stiffness and percent relaxation, we saw a decline or an increase, respectively, showing worse mechanical properties for the dry needling treated tendons compared to the focused ultrasound treated tendons compared to control. So that was very promising that we are seeing a response, but that at least in a couple parameters, focused ultrasound seemed to preserve mechanical properties better than dry needling. So in short, we have found that focused ultrasound can create microdamage and elicit a healing response similar to dry needling. We saw this in the release of growth factors and in histological remodeling. However, we found that focused ultrasound might be slightly better than dry needling in maintaining the stiffness and percent relaxation of the tendon. So focused ultrasound does show potential as an alternative tendinopathy treatment. We of course have more work to do, both in the guidance and monitoring, moving to larger animal models, but it's very exciting to see that this has a potential non-invasive therapy for treating tendinopathies. To thank my group, our collaborators in the Muscle Lab, and our funding source, the National Institutes of Health, and thank you for attention. I'd hope to see some questions or interaction on the virtual platform. Thank you very much.